I'm Angela DeGrassi, Senior Research Manager for Patient-Centered Research at the Global Healthy Living Foundation. Today, we're speaking with leading experts on polymyalgia rheumatica, or PMR, as part of our ongoing work to better understand this challenging condition. We're working on an education and awareness campaign through a grant awarded by the Center for Disease Control and Prevention. I'm managing this project and excited to share an update on what we're working on. We've conducted a comprehensive review of the existing literature on PMR to explore what is known about its clinical presentation, symptoms, diagnostic criteria, and treatment approaches. Additionally, we've analyzed large data sets, including electronic health records and insurance claims, to uncover patterns in diagnosis and prescribing practices for PMR. By combining insights from both published research and real-world data, we hope to identify gaps in current knowledge and improve the clarity of the PMR pathway for patients and healthcare providers alike. Today, I'll be speaking with Dr. Mike George and Dr. Jeff Curtis, who are both advisors on this project. Dr. George is the Assistant Professor of Rheumatology and Epidemiology and Fellowship Program Director at the University of Pennsylvania. Dr. Curtis is Professor of Rheumatology at the University of Alabama at Birmingham and Chief Medical Officer at Illumination Health. Thank you both for joining us today to discuss these crucial insights. Let's start with Dr. George. Dr. George, PMR often has symptoms that are vague and can be challenging to diagnose. Can you share your thoughts on the importance of raising awareness about PMR among healthcare providers?
Yeah, I think that's definitely right. I mean, many people come to the office with shoulder pain or hip pain, but identifying when you should think about PMR is really important, especially when it comes on suddenly. There's new stiffness as a big part of it in an older person.
I think that the clinical suspicion is among the most important things to have going into any scenario where somebody who's older feels a little bit achy. They may just have the blahs. It can even manifest as depression because people don't feel good. And sometimes PMR is hard to detect because unlike certain forms of arthritis where you can see lots of joints swollen, people with PMR often don't have that easily visible. They're large joints and they may just have hips and shoulders feel achy. So I think that the diagnostic suspicion that that might be what's going on in somebody who has new and persistent symptoms is among the most important things to get people a diagnosis.
What impact do you think a clearer understanding of diagnostic and prescribing patterns could have on patient outcomes?
I think it's very helpful that we understand both the diagnostics and the prescribing patterns, but also what kind of providers the PMR patients see. Most PMR is not taken care of by a specialist like a rheumatologist, but rather lives in the world of primary care. There's a lot going on in primary care settings, and understanding who's taking care of these patients and making sure that patients have access to the best treatments, including some of the newer biologics like sarilumab, is quite important to get the patients the care that they need in a timely fashion.
Well, I do think we need to know more about who's getting diagnosed with PMR, who's making that diagnosis, and how they do in follow-up. Because, what we've observed is there can be two main ways that things go. One, that people are treated for a short time, do very well, come off of all treatment, and other people who need long-term treatment. And figuring out early on which group this is going to be and are we treating people appropriately, I think is very important.
Right. So are people going to a rheumatologist or is it their primary care provider giving the diagnosis? And in your own practice, what are some of the challenges you are seeing in diagnosing PMR?
Yeah, I mean, the biggest challenge is that there's no one diagnostic test that says for sure this is PMR. So diagnosing the disease requires, having familiarity with it, having seen it before, and also once you start treatment, thinking hard about whether you still have the right diagnosis. So if treatment goes according to plan, you feel much more confident that you're on the right track. And when it doesn't, making sure you're able to rethink the diagnosis.
Because the symptoms can be nonspecific. Sometimes people just don't feel good, or they chalk it up to aging or other life changes, perhaps at the time of menopause for women. So it can be an important mimic for people who either don't feel good or just chalk it up to some of the otherwise usual things that they're accustomed to or expect as part of normal as part of aging.
And right now, treatment relies heavily on glucocorticoids. As you look to the future, what is your hope for PMR patients?
I think this is a great question. I mean, we're now across many autoimmune rheumatic diseases, looking hard at glucocorticoids. How much are we using? What are the long-term and short-term toxicities for patients? So, there are some people with PMR that can be on glucocorticoids for a very short time, come off quickly, they feel great, and I think that's a big win, especially if they're not having side effects. But for either people who have side effects or people who need more long-term treatment, we have now some emerging therapies that can be used, and we need more options for people to help avoid that toxicity.
And that is exciting, and we have to let healthcare providers know that that's available and how to use it effectively.
Well, I think also, previously many patients with PMR were treated primarily by primary care, and I think for a good primary care doc, that's still appropriate. But when you get to the point of needing long-term glucocorticoids, that's where I think rheumatologists need to step in and play a bigger role.
And many times patients are taking glucocorticoids for steroids. What would you tell a patient that's been prescribed glucocorticoids for a long period of time?
Well, with glucocorticoids, it very much depends on the dose.
Yeah.
And so I think discussing, with your physician, some of the long-term issues with glucocorticoids, at a low dose, many patients can take this for quite a long time. And if it's really helping in their disease and they're not able to come off, it may be a really good treatment option. But making sure that bone health is being monitored, making sure that other long-term consequences like blood sugars are being assessed, I think is really important.
Great. So checking in, monitoring, and knowing symptoms for some of these other conditions that could have a longer-term impact.
That's right.
And what can community and patient advocacy organizations do to help build PMR awareness?
This is a very common condition for people who are older. And knowing I need to ask my doctor about this, or this is a question that I have in my mind so that they think about it, raising awareness and thinking about it in the office is critically important. Some people might just suffer with this for months without even seeing their doctor. So I think it's really important.
Why do partnerships matter between patient advocacy organizations, industry, and clinicians on the topic of PMR?
Partnerships matter because it's going to take a team. Raising awareness amongst providers, both primary care physicians and specialists like rheumatologists, helping patients understand what this condition is, the fact that this could be a lifelong condition that is going to either need to be treated or may need longer-term treatment, and then having patient advocacy organizations support patients in their journey and talk to other patients who have this. It's a rare disease. This is not very common, and most PMR patients won't know anyone else with PMR to talk to and get support from. So PAOs are very helpful in that regard.
What is the relationship between PMR and vasculitis?
So PMR has high overlap with giant cell arteritis. So that is a form of large vessel vasculitis. In the world of GCA, which is that vasculitis, about 20% of people may have PMR. The overlap in the opposite direction, PMR patients who have or develop GCA, if they start with PMR, is less common. But whenever someone has giant cell arteritis, that form of vasculitis, you should think about PMR and vice versa because they can co-occur.
So if you start having those symptoms, it's best to contact your provider right away.
Definitely, yes. And some of the symptoms like troubles with chewing, or what's called jaw claudication is the medical term, those are important for clinicians to be aware of and to recognize in anybody with PMR who might not yet be diagnosed with any form of vasculitis.
And in your opinion, what are the most significant knowledge gaps in PMR care that future research questions should address?
That's a great question. Well, I think there's a few. One is it would be great to have better testing for diagnosis, to be more confident early on rather than, okay, let's treat and see what happens, because I've seen that go the wrong direction many times. And the second, I think, is being able to identify who is going to be a short, once and done condition and able to come off treatment and who might need long-term treatment. And if we were able to identify that early, we'd know better how to treat people early on.
We have lots of new things that we need to learn and have had some advances about treatment, but there's a lot yet to be known. We have one new therapy, sarilumab or Kevzara, that has shown in clinical trials to be very effective in treating PMR. That said, there's a lot we don't know, like how long should patients be on it? How long could they be on it if they need prolonged therapy? How do you take it away? Do you put it back? Who are the best patients to get it, and how quickly should they get it after a trial of glucocorticoids? So we know it works, but how to best use it and in whom, those remain important evidence gaps we need to fill in.
And for a patient that's newly diagnosed with PMR, what is your best advice to them?
I think it's important to know that steroids are not your friend. And steroids may be the devil you know. And other therapies like the IL-6 biologic sarilumab I mentioned is maybe the devil you don't know and has an associated side effect profile that people need to be cognizant of, but long-term steroid use in an older patient is almost always bad news. There's a host of side effects, and yet people may just get used to it or think that it is an expected part of disease treatment, but long-term steroid toxicities should not be tolerated without trying another option, and we now have other options.
Great. That was very insightful. Thank you for answering these questions, and thank you for your partnership on this project.
Certainly.
Thank you so much.